Case 6 is side 947036.
All right, the issue here is melanoma versus Clark's nevus. Right? And I urge you not to be distracted by the lymphocytes, right? Because that's the easiest thing to occur. The lymphocytes are distracting in a lesion like this. Always focus on where the action is. And the action is the melanocytic component. It's not the lymphocytes. Now, if the lymphocytes were all on one side and not on the other, then you say, look, it's asymmetrical, favors melanoma, or it's a combined nevus. In this instance, we have a dense infiltrative lymphocytes, and it only is distracting. Now, in my opinion, this is a melanoma. And it's a melanoma because there is scatter of melanocytes at all levels of the epidermis. The nests are confluent. They're not equidistant. But we have to go down now and corroborate that. And we're going to look for that. We're going to use the same criteria that we've been employing. And we're going to see, is this a melanoma or is this a Clark's nevus? Because that's the issue. And we go across it. Most of these melanocytes are arranged in nests at the junction. But the nests vary in size and shape. And there's skip areas, do you see? Nest there, and then a little skip area, and nest and nest. Broad lesion, but well circumscribed. You see it here? Mostly nested at the junction. Mostly nested at the junction. Mostly nested at the junction. How about that? Mostly nested at the junction. Now here, it's cut at a tangent. You see this? And so here's a problem, and you don't want to misinterpret. First of all, there's a mitotic figure here. Do you see this? See mitotic figure? There's scatter of melanocytes, and you have to be sure. And here's single cells predominant over nest in this adnexal structure. Now, single cells predominate, single cells above the junction. Confluence, single cell above the junction. Confluence. Now, this is a very interesting and challenging case because there are lots of features in common here between a Clark's nevus and melanoma. Despite the features in common, I favor melanoma here, but I want to look a little bit more. Confluence of nests across a rather broad zone. Then nests not equidistant. Within the dermis, there are bizarre shaped aggregations. This is a melanoma. Does everybody see this? Look how bizarre these aggregations are by virtue of confluence. Bizarre shaped. Scatter of melanocytes. There's a melanocyte in the cornified layer. Melanocyte in the granular zone. Nest not equidistant. Confluence. So this is a very instructive case because there's so many features in common. You see the lamellar fibroplasia, the concentric fibroplasia, the lymphocytic infiltrates, the telangiectasies. All those things that are supposed to be, you see the melanocyte in the granular zone, supposed to be diagnostic of a so-called dysplastic nevus. Look at this, melanocyte in the granular zone. All the features of dysplastic nevus, as articulated by Clark and coworkers in Human Pathology in 1985, are fulfilled in this section. Namely, I just want to call them to your attention so that we're on the same frequency. There is what they call persistent lentiginous melanocytic hyperplasia. That means an increased number of melanocytes arranged as solitary units in thick and reedy ridges. For example, here, you see there are an increased number of melanocytes in this elongated reed. And then there are abnormal melanocytes, and there's lamellar fibroplasia, and there's concentric fibroplasia, and there are lymphocytes. But this patient has a melanoma, and not a nevus. And it's a melanoma for the reasons I've mentioned. At scanning magnification, you can see that the lymphocytic infiltrate is not distributed in symmetrical fashion. If you draw an imaginary line here, there are many more lymphocytes on this side than there are on this side. Once one looks at higher magnification, and even at lower magnification, you can see that the nests are not equidistant. They vary in size and shape. They become confluent. There is scatter of melanocytes at all levels of the epidermis. And within the dermis, there are bizarre-shaped aggregations. So this is a melanoma. And I think it's important to take note of the fact that all the criteria do not obtain in every case. This lesion happens to be very well circumscribed. That's the last nest. That's the last nest. This lesion consists mostly of melanocytes arranged in nests rather than solitary units. So in difficult cases, there are always features in common. If there are no features in common, the diagnosis is a snap. It's not a snap if there are features in common. And the more features in common, the more difficult the diagnosis. And here, this lesion is well circumscribed, it's mostly nested, and the nests are at the junction. Right? Now, you shouldn't be distracted by lamellar fibroplasia and concentric fibroplasia, et cetera. That they don't help you. But for the reasons mentioned, this is a melanoma.
Are there any questions or discussion?
Dysplastic nevus, the nests are not necessarily equidistant, isn't that correct?
Well, you know, these phrases like equidistant are guidelines. They're guides. Nothing's ever equidistant in nature. It's just the impression of being relatively uniform in size and shape, relatively equidistant, as opposed to being surely not equidistant. They're much more regularly positioned in the epidermis in Clark's nevi than in melanoma. And the way I think about it, and maybe it'll be helpful to you, is this. Nevi are benign neoplasms for practical purposes. We're not going to discuss congenital nevi. We're talking about Clark's nevi. And they're a little neurotic. They're obviously not normal. A nevus is not normal. It's abnormal. That's why you read about them in textbooks of pathology and not in textbooks of embryology or histology. Malignant neoplasms, melanoma, are psychotic. So a little neurosis produces a lesion that is symmetrical, well circumscribed, nests mostly at the junction, equidistant, relatively uniform in size and shape, etc. Melanoma is asymmetrical, poorly circumscribed, nests not equidistant, vary markedly in size and shape, become confluent to form bizarre shaped aggregations, etc.
Yes, Bob?
Do lesions like this that are hard to diagnose that are melanoma behave biologically better than ones that are easier to
Now
diagnose?
the question is there any correlation between difficulty in diagnosis and biologic behavior? This is the only correlation. If you miss tough melanocytic neoplasms like this one, it alters your biologic behavior.
Are there any further questions? Or, yes?
At previous conferences, this must have been removed by a dermatopathology resident, but Bernie has referred to them as little shapers. My question is when you have a pigment and lesion, why don't they use a surgeon's creed? When in doubt, take it out. And if the margins of resection are free, would you advise going back or leaving it go?
Well, let me start with the latter. If the lesion is excised completely, and the pathologist can state to the clinician, the lesion is out, and it shouldn't be fanciful, it's a statement of fact as best as you can perceive it, nothing more need be done, irrespective of the thickness of the melanoma. If it's out, there's nothing more to do. Now, so far as the first part is concerned, this is not the time for a philosophical treatise because we don't have the time. But in my estimation, in a word, it has to do with bad training of residents. Only somebody who's badly trained would do this for a suspected melanoma. Now, if they think it's a seborrheic keratosis, that's an entirely different story. They have every right to shave it. But I can tell you, because we did the study, 53% of all the people sending specimens to our laboratory in New York City in the early 80s, say 83, over a 5-month period, who suspected melanoma. On the request slip, it said, rule out melanoma, melanoma. Melanoma is written there. 53% removed them by either shave or punch technique. They're the facts. I think it's bad training. I think you're right. You suspect a melanoma, one should excise it in one shot, and that's it. It makes it much better for everybody, including the histopathologist.
In defense of the clinician, the entire lesion is here, which should not handicap us as dermatopathologists.
No,
and the specimen is not
I'm
stretched, it's well preserved.
This is not an attack on the clinician. The clinician doubtlessly is a very fine person, treats his wife beautifully. I told you, didn't I? Absolutely.
But he's not a little shaver.
Well, he's a big shaver. I'm just suggesting to the clinician the next time, if he suspects melanoma, I mean, he may not have suspected melanoma, but if he suspects melanoma, instead of taking the blade of the scalpel and putting parallel, it's better to do it perpendicular and to cut it out, because they had to do another procedure on this patient. They didn't let this go now. It was called melanoma, I assume.
This was called melanoma. It was re-excised, and there was no residual
but
tumor.
the question was, why not cut it out the first time, then you don't have to re-excise it? I think it's not unreasonable.
No, this is not my case. It is from my group. So I rose to the defense of my...
Right, but it's a little chauvinistic and parochial, don't you think?
I think the criticism, I think it's still better stated that the tissue needs to be presented to the dermapathologist in a form in which they're able to make the diagnosis with ease. And if you have the entire specimen here...
Right. But Joe, we're talking, let's make believe there were no grown-ups here, only residents. If there were residents only, we wouldn't say to them what you just said. We would say, look, there's the right way to do it, and there's all kinds of other ways that are not bad or wrong or crimes against humanity, but there is one best way to do this. And the best way, because everybody is crazy about dermatologic surgery now. I mean, they're crazy about dermatologic surgery. Why can't they do a biopsy? They put ears where the umbilicus is. They do all kinds of other tricks. Why can't they just excise it right? So I must say, I am in complete agreement with the person who asked the question. I'm not for a moment saying that this is negligent. Absolutely not. I'm merely saying, why not get into the better habit? And the better habit is one procedure with a margin. And I'm not going to give a number, just a margin. And get it out, finito. At least that's my view.
Well, I suspect that clinically this lesion was well marginated, as we talked about. It is relatively symmetric. It probably didn't have, it was not one that clinically was a high degree of suspicion of malignant melanoma.
Well, that's a different story. That's an entirely different story. And I said from the beginning, if there were a differential here, or where they suspected seborrheic keratosis, I wouldn't say that there was anything wrong with that. I'm really saying that there are times when the clinician says, that's a melanoma, and does a procedure like this, and I think we should decry it.
One more comment?
Yeah, quick comment. As a dermatological surgeon, unfortunately, there are standards of care that you have to follow in your particular community. One of the standards of care has to do with margins when you remove a melanoma, despite the numbers that you want to put on there. If you don't do that, not everybody can afford to have Bernie come and, testify in their behalf that just removing that and there wasn't any residual was good enough. You do have to take these people back, and you do have to follow certain criteria. You put yourself at very high medical, legal.
Right, but I think also, I acknowledge what you say. However, there also is the personal responsibility that supersedes the law. And that is, what Antigone is all about. There was a time in my professional life when 5 centimeters wide and deep to fascia was routine. I mean, that's the way I was trained. That's what everybody did. Now, what happened to those numbers? You don't have to be a genius to figure out they're getting smaller. Everybody, even Balsh, if you can believe it, is down to 2 centimeters. I mean, from 5. Now, what's the logic of it all? The logic is you got to get it out. Now, I don't think that we should practice according to what the lawyers say, or anybody else for that matter. One of the problems, and I'm not going to sustain this, but I'm just going to mention, one of the woeful aspects of the woeful state of medicine now is that doctors didn't assert themselves as they should have. They let it be taken away from them, their profession, taken over by crummy businessmen. It's our profession. Who sets the standard? We set the standard. Now, if what I'm telling you is unethical, that to get the melanomas out is enough, I mean, if that's flawed, if there's something wrong with that, then you have every right to criticize it. But if, in fact, it's correct, it's accurate, it's logical, it can't be refuted, there's not one jot of evidence to the contrary, every single paper, without exception, that's written about prognosis vis-a-vis margins states, and I quote, there is no correlation between survival and width of excision. I mean, what is one to conclude? In any event, we don't want to get sidetracked here because our issue is diagnosis and dermatopathology, but we are not isolates. A person behind a microscope is tied to a clinician who's tied to a patient. So in that way, we're tied to the patient too. What I'm suggesting is that we serve the patient best by removing suspected melanomas at one shot, and that's it. Fartic, basta, finito. We are now on the defensive because of the cost of medical care. One day, I promise you, they're not going to be doing 2-step procedures. Do you remember in 1980, 81, and 82, we had to do 2 removals of dysplastic nevus to prove the syndrome, and then almost all the dermatologists had them re-excised? We're talking about neva. That was just 13 years ago. So we must have Promethean views. We can't have short-term views. We have to have a sense of historical perspective. I acknowledge that mine tends to be a little bit of a caricature of the norm. At the same time, I think that somebody has to appeal to the better instincts in human beings. And I think that in a case like this, I am not denigrating the person who did this. I don't know what the lesion looked like. I don't know what the circumstances were. There's a general principle that was articulated, implied in the question. And that general principle is, I think that a competent, well-trained person in dermatology who sees what they believe is a melanoma, or he or she believes is a melanoma, should, if it can be excised completely, should do it. And let's say you want to take 2 centimeters. If it's obviously a melanoma with regression, you can take, if you want to do it, do it. You don't have to go back and do it a second time. So these are issues to be pondered. They're not ex cathedra pronouncements, but there should be an articulation of that point of view.
We have the carousel, please. patient is a 27-year-old white female with a pigmented lesion in the lower left abdomen. The lesion had been asymptomatic. The follow-up was the lesion was felt to be a malignant melanoma, as we said, re-excised, and there was no residual neoplasm. We are 2 hours into the session and 15 minutes past our break. You want to take it? Should we take it now? What's the?
The answer
We're
is
ready
yes.
for a break.
Yes.